Well, for once, I could say good morning on this webinar because I'm actually in the Chicagoland area and it is still morning here. But for most folks on the call, I think it's at least it's the afternoon. So good morning, good afternoon, depending on what time zone you're in. Brandon Garrett with the National Minority Quality Forum, just here to do a brief intro on today's webinar. It will be led by our very own Leslie Zuniga-Rivas. And we're talking about the work they've been doing in colorectal cancer. So before I turn it over to Leslie to give you the official and tell you about the amazing, we'll tell her about her amazing self and then about our amazing panelists. Just gonna give you some updates. One, if you have a question that you like our to ask our panelists, please put in the Q&A box, and then Leslie will get to that as our moderator soon enough. And two, if you just want to kind of keep the conversation going, if you have any announcements or anything like that, put in the chat and everybody will see it and we may respond to it. But outside of that, I just have one wish everybody a happy Friday. First of all, if you celebrate Easter, have a good Easter weekend and Good Friday. And then finally, in a month, exactly a month for the day, is our National Annual Summit on Health Disparities, where you'll hear more conversations like this in person, led by people like Leslie and Anna and Laura Lee and Ashley and myself, and the two docs on the panel. But I don't want to steal any thunder, so I will go ahead and turn it over to Leslie to lead today's program.
Thank you so much, Brandon. Hi, everybody. Welcome in. My name is Leslie Zuniga, and I am the Quality Improvement and Equity Project Manager for NMQF's Center for Sustainable Healthcare Quality and Equity. As we know, March is Colorectal Cancer Awareness Month, and we wanted to take some time today to discuss screening, patient engagement, and community connections. We will also be highlighting the great work between Rush University Medical Center in Chicago, Illinois, and SHC as part of our colorectal cancer screening drive program. Our drive programs consist of equitable quality improvement implementations. Our goal for our colorectal cancer screening program has been to increase screening rates within minoritized communities. We have partnered with several clinics throughout the country and health systems. We have also partnered with our community partners, those being our Hair Wellness Warriors and our Faith Health Alliance, to overall just spread awareness for CRC screening within their communities. And again, before we jump in, I wanted to remind everyone of the Q&A function. So feel free to drop in any questions that you have. We will be answering those towards the end. And I also wanted to welcome and thank our panelists for joining us today. Thank you so much for sharing your expertise with us. Today on our panel, we have Dr. Ellie Balilos. Dr. Balilos is a resident physician in internal medicine at Rush University Medical Center. We also have Dr. Marie Campbell Statler. Dr. Statler is an assistant professor at Rush University College of Nursing. And we will also have Dr. Divya Venkat, also from Rush University Medical Center. Colorectal cancer is the third leading cause of cancer deaths in our country, and it unfortunately heavily affects the younger Black male population. NMQF's work is centered surrounding health equity, so I thought that would be a great way to kick us off today is with a health equity question. And Dr. Balilos, I'll go ahead and get started with you. But why do you think colorectal cancer screening is important, particularly within the context of health equity and community health?
Yeah, no, absolutely. I think that, like from a big overarching theme perspective, colorectal cancer screening is just so critical because colorectal cancer is so preventable. Like if you look at the progression from polyp to cancer, that's generally like what we see. And if we follow screening guidelines, we are able to catch most of those polyps before they turn into cancer and become a bigger problem. And what I've seen and what we see, especially in minority populations, is a significant drop-off in screening according to current guidelines. A lot of that, and we'll get into this, I'm sure, a lot today, but a lot of that is due to like a historical mistrust of the system, but also it's due to some unawareness of some advances that have been made in the realm of colorectal screening. There's a lot of changes that have been made in recent years that have made it more accessible as well. So we'll talk about all of this today, but it's just so important because it's a very preventable disease. And we're also starting to see it now in much younger populations as well. So it's only going to become more and more prevalent. And I think we're only going to continue to see more about it in the news about younger people getting it. And unfortunately having worse outcomes because it wasn't caught sooner.
Yes, absolutely. And I know, the screening age was recently in the last couple of years lowered to 45. And I mean, I wouldn't be surprised if here in a few years that's lowered even further.
Yeah, me neither.
And Dr. Sattler, I also wanted to ask you the same question. So, when thinking of why screening is important, especially with health equity and community health, any input that you have towards that?
I think it's an excellent question. And once again, just thank you. I think it's an honor to be here, especially during Colorectal Cancer Awareness Month. So when you think of community health, you also have to think about reducing health disparities amongst various populations. It's important to know more specifically when you look at the incidence and mortality rate when you're dealing with colorectal cancer, there's differences that are related to factors such as a patient's race, a patient's gender, social factors, where a patient lives. And so when we talk about health equity, especially, we're talking about ensuring equal access to quality care. That's critical. So colorectal cancer screening is one way to actually reduce those disparities, and it's a bridge to preventing disease. So when the whole community receives colorectal cancer on a timely basis, then we're creating a more equitable and more healthier society. So that's why it's very important that we actually increase colorectal cancer screening preventive efforts, especially targeting in communities that are hard hit communities.
Absolutely.
Mhm.
Absolutely. Thank you so much for sharing that. And next we have Dr. Venkat. Thank you so much for joining us today. And I wanted to start us off with the health equity question, since that's what our work here at NMQF is centered around. But why do you think colorectal cancer screening is important, especially when talking about health equity and community health?
Sure. Yeah. My name is Divya Venkat. I work at Rush West Loop. Thank you for having me. It's a great question. So one honestly huge reason I think is that screening in general is a huge part of prevention. And prevention is really what helps more stabilize the playing field. So a lot of the things that we notice discrepancy as far as like health equity also has to do with the fact that some populations have greater access to healthcare and health resources than others. So if we catch things early, we're able to treat them. We're able to, prevent things from getting to a serious stage, which then affects all aspects of your life, right? So if you're not healthy and you're dealing with these medical issues, you're not able to do anything else really. It becomes the forefront. So that's a huge reason, is that since we've come so far, thankfully, with advances about screening, but also with treatment, right? Making sure that we're on top of things early for people and catching things makes it so we take care of that part and they can just take care of going on with their lives and caring for their families, which is what's important to most people.
Absolutely. Thank you so much. And since, we already kind of started the discussion surrounding disparities, I think something to also think about is you guys are based out of Chicago, which, I think is still a city where we see a lot of disparities, unfortunately, especially within colorectal cancer, both in screening rates and mortality rates, especially within the Black community. Do you think this is why do you think this is? And also, is this something that you are seeing firsthand? Obviously it's one thing to know about it and hear about it, but is it something that you're actually seeing within your work?
Yeah, absolutely. I mean, I think, so I was just at an event earlier this week that we'll talk about, but Dr. Lee, one of our other physicians who's kind of helping out with this project, but wasn't able to join this panel today, actually showed some really interesting graphs that really blew my mind. So basically, like I don't have them with me right now, but the statistics they have shown that like in the last few years, we've actually like nationwide overall improved colorectal cancer screening rates, but also mortality rates have gone down. And we basically attribute that to our screening practices are working, right? But when you break it down by race, and especially Black versus other, it's really striking. Like they're actually going up. So like everything else is kind of canceling that out, but we are not targeting, like we aren't reaching certain communities with our screening strategies. And I think that's something we need to really figure out. One, why is that happening and how do we fix that?
Absolutely. And Dr. Statler, I know, you're just dipping in or starting into the research field, especially in the context of colorectal cancer. But is there anything that you would like to add to that, or any other thoughts that you have surrounding the disparities seen within screening rates, especially?
Absolutely. So, African American men have the highest incidence and highest mortality rates than all races combined when it comes to colorectal cancer. And so, when we reviewed the literature, we identified that the barriers to colorectal screening were multifaceted. It wasn't just on the individual level. There were interpersonal barriers, there were barriers, community barriers, there were barriers that are systemic structural barriers, as well as policy barriers. So when we think about the barriers being multifactorial, we also have to think about how can we leverage the community? How can we leverage the healthcare community, the African American community, advocacy groups that come together as a synergistic force to attack these barriers in multiple areas, just not one area.
Absolutely. And
Yeah.
I know oh, sorry, Dr. Venkat, go ahead.
I was just going to add to it. So I was going to say, honestly, based on my conversations with patients as well and my experience, right? A lot of people have expressed to me, your demographic makes a big difference whether or not you trust the healthcare system, right? So there's historically, right, we don't need to go into all the history, but it's really interesting and sad, honestly, historically, to look into how demographic makes a difference with how patients and the general populace are treated with respect to doctors, right? It's a lot of groups will inherently not trust the system because they expect a certain type of judgment and treatment, right? So it's colorectal cancer is, of course, a huge thing that is a disparity, but in general, people are just also not seeking out preventative care. So it's part of the project that we're working on with one of the clinics in main hospital at Rush, and then also my clinic, is we analyzed some data last year, basically looking at based on race, right? What is the amount of people who are getting their screening completed, right? And that itself is pretty significant, right? So if we look at raw data itself, if you look at solely like Black and white populations, those were more similar as far as number, but the percentage almost had, depending on the type of, how else you adjust for it and the type of time of year and things like that, there was almost like a 5 to 10% difference on screening grades, right? It was huge. And that goes for other minorities as well. Hispanics were another one that was even lower too. Asian Americans were actually a little bit higher, but still lower than Caucasians, right? So it's this big thing that, number one, a lot of people, many times that's not their priority, right? There's also big socioeconomic differences that unfortunately play a part as well, right? But then there's also is it ingrained in my system to go into the doctor and get a regular preventative healthcare screening, right? And am I someone that can afford to take time off for a colonoscopy, right? Do I even have a network of people that can tell me that's not the only option anymore? Or is that really secondary to me? And a lot of people, especially people that are colon cancer screening age, right, are parents, right? They're caring for their own parents, and their health, unfortunately, does not become a priority, right? Especially in communities that are more, multi-generational. So it's a huge thing where I think that we've been treating our entire patient population as the same, right? But there's so many differences between what people prioritize and people's relationship with doctors and the healthcare system that, I think we're barely starting to scratch the surface of saying we shouldn't treat people differently, but we should try to find out what changes people's experiences and trying to help connect them to those resources rather than just expect them to come to us.
Absolutely. Well, thank you for, kind of shifting our conversation towards my next point with health equity, in the context of health equity, you know, we spend so much time discussing disparities. You know, we discuss so much what the problem is, but oftentimes we don't make that switch over to what are the solutions, you know, what we need to shift our focus over to, you know, and really overall, you know, being flexible, learning from our communities. And I know I shared a little bit more about our DRIVE program for our colorectal cancer screening project, which Rush has been a great partner to work with. And I know Dr. Venkat and Balilos have been leading our work there. But I wanted to see if you could share a little bit more about, you know, the implementation, especially, you know, how this was formed and any barriers that you identified. So if you would be able to walk us through a little bit through that.
Sure. You're talking about the project we're working on now.
Yes. Yes.
Okay. Yeah. So honestly, so far, well, a couple of things. So the first thing that I think that, you know, you learn in like public health and in general with community health is if there's an issue with access or an issue with a certain medical condition in a community, the first thing you should do is ask the community, right? So, you know, the things we wanted to do is we wanted to ask our patients, we wanted to ask, not even that, we wanted to figure out from the doctor perspective, right, or the resident perspective, how are we approaching this even? Because frankly, it's our method that needs to change, right? So we initially were thinking, you know, we're going to do a community survey. We're going to do a survey of the physicians that work in our offices, things like that, right? The community survey part didn't unfortunately pan out just because of logistics. So instead, what we did is us along with Leslie and other people in NMQF, we had our own little meeting with some of the community engagement people that we have and talked about what their experiences with their community were and what they've noticed were barriers, which I think was super helpful in figuring out why people don't necessarily connect to care or don't want to, you know, or things like that. And then the physician part, I actually thought was super interesting because it's one that I think we don't focus on that much. And a big part of it so far that we've noticed is honestly, that we're not educating patients on what the options are, right? And we're not necessarily educating patients on why they should do these things. So a big part of what we rolled out, right, which Dr. Bilios and another one of our residents, Dr. Oh my gosh.
Dr. W.
Yes, Dr. Yeah. Okay. Her and Dr. Zimmerman, right? Apologies, have been working on, right, is we worked on a kind of like screening tool to talk over with patients, right? So what we've been doing is so far we've instituted this in several of the clinics and all the exam rooms where we have like a laminated sheet with basically the main reasons we want to get screened, what reasons there are to get screened, and then the basic options that we recommend. And what I've been doing, right, which I think a lot of us have been doing, is when we have the conversation about colorectal cancer screening, and especially when people look hesitant, right, I pull it out, we talk through the options, we talk through what aren't options for people depending on their history or family history, right? And then based on that, we make a decision. And the reason I think it's important is number one, you should always know what you're agreeing to with your health. But number two, you're making a patient a part of the decision instead of just telling them, hey, go get a colonoscopy. You know, and we still are in the data gathering aspect of this project to figure out, you know, is this actually going to increase incidences of screening or incidences of how people are ordering these tests? But so far, at least, I feel like just anecdotally, I've seen a lot more people that maybe are willing to do the non-invasive tests that wouldn't be screened otherwise, just because there's so much hesitancy. So that's my spiel on it. I'll go ahead and pass the mic over to Dr. Belios to see whether she has any other thoughts.
Yeah, no, I mean, I think it's been a great implementation so far. So I'm one of the residents at Rush, and I work in the internal medicine primary care clinic on a weekly basis. And we, as Dr. Venkat alluded to, we've basically laminated one of these tools and put them in all of the exam rooms. And the goal with the resident workflow, because the resident workflow is a little bit unique as far as doctor's offices go. So like if you're seeing an attending physician, you're going to have the MA room you, take your vitals, that kind of thing. And then you'll get changed if you need to, and then the doctor will come in. If you're being seen in a resident clinic, what's unique is that same thing, the MA rooms you get your vitals taken, you get changed if you need to, but the resident will then come in initially first and talk with you and kind of, I mean, they are your doctor. But with the caveat that they have to kind of go over things and what we call staff with an attending physician who kind of oversees their work as they're still in training. So our goal on the resident side of things has been to kind of encourage all the residents in the clinic, if colorectal cancer screening is on the table for that appointment, to give the patient the opportunity to kind of review it while they go to staff with the attending, because there's a little bit of downtime and the patients are kind of sitting around during that time. And I think that's been working pretty well, because it also allows, I think it's good to go over it with your patient. If it kind of depends on the situation, right? But it also allows patients to kind of review it in private and with like a no pressure situation, which I think sometimes if they're with you and maybe they're even meeting you for the first time, it can be a little uncomfortable to feel like pressured going over things. So it really depends on the situation. I will say it's a patient to patient basis, but that's on the resident side. We've been trying to kind of implement it into that workflow. And I do think it's been going pretty well. The biggest thing being like educating patients on all of the different options, just because I think a big issue is that people just don't know about a lot of these options. And so if they are given that information, then they can make a more educated decision. And like Dr. Venkat said, the decision that they make is then a decision that they've made. And so they're much more willing or much more likely to actually follow through on that, as opposed to being told to do something.
Oh, absolutely.
Even if they end up deciding to go with a colonoscopy, you know what I mean? Then at least they've decided.
Absolutely. No, I think it's a great, thing to just be able to sit down and have a conversation and review, the options that people might have. Because, the misconception out there is still that colonoscopies are the only options. But I think it's also great to see, that your implementation isn't just surrounding, the patients, which is absolutely great, but you're also, working so well with your clinics, and you surveyed, all of your staff just to see what would work best. So I think that's wonderful to see. And Dr. Statler, I saw you nodding your head several times. So I don't know if there's something that you wanted to add to the work that's being done.
Well, when I heard about the work, I thought that it was excellent. I mean, based on, even what I'm hearing today, there's shared decision making, there's additional education that's being provided to the patient, which is extremely important because one of the barriers to colorectal cancer screening is education, lack of awareness, what type of screenings are available for me. And it just being educated in those clinic settings is critical. The other thing I want to highlight is that the importance, when I heard about the programs that are in the churches and the hair programs as well, when I first heard about that, it made me think about we're utilizing acid-based approaches to improving population health. And these are strategies that focus on leveraging the strengths of the community versus focusing on the problem. When you engage in these types of partnerships with churches and health salons that have well-established social networks within the community, that have a long-standing reputation of not only caring for the community, of building the community, but also protecting the community, right? That is a way to actually build sustainable programs that will last and improve the health of the community. So when we work together with these champions in the community, that type of partnership cannot be underestimated. We understand that as we recognize the community as experts in the partnership, they're experts of their lived experience, they're experts in understanding the historical underpinnings of their community, and coming together with the experts from the healthcare community, that creates a win-win for improving the community health. So hopefully we can see with these efforts, those colorectal cancer screening rates increasing from 60s to the 80% that we're looking at the national roundtable. And that 60% may not be accurate, especially coming off the tail of the pandemic, because that significantly put a halt to colorectal cancer screening.
Absolutely. And I I think it's great that you mentioned our community partner programs. So I wanted to give a little bit of background on that, and then open up the floor for both for all of our panelists to share their experiences with that. I know some of you have had the pleasure of attending and providing resources and information to our community partners. But as part of this program, as I mentioned earlier, we are working with our community partners, that being our Faith Health Alliance, which is a network of churches throughout the country. We also have our Hair Wellness Warriors, who are a network of barbers and stylists, predominantly in minoritized communities. And they both do such a great job at, really normalizing conversations, spreading health education and information, and also, even just having access, things of the sort. But I wanted to, open up the floor and just see if Dr. Venkat, if you wanted to share your experience with our Faith Health Alliance event that we had a couple weeks back. So we had an event at the Friendship Baptist Church where I know several of your team members were present to be able to give a presentation on screening rates and answer any questions that attendees had.
Yeah, of course. So I thought it was a really great event. We basically, what we did is we organized a bunch of us, and also nicely from different levels of training as well, because I think part of it, of course, is educating ourselves, which we skate over a lot, right? But we planned to go there, right, to the Friendship Baptist Church on a Saturday, right? We set up an event where we're basically going to do, what is colon cancer screening? Why is it important? What are our options? And Dr. Lee, who's one of the gastroenterologists, one of our residents, and then one of our med students also gave talks. So 3 separate talks on basically what can we do to prevent colon cancer, right? What are non-invasive screening methods, and then talking more about colonoscopy. And then, Dr. Lee has a really great presentation where she basically goes through and shows everyone, right, what a polyp looks like and how things can be missed and how they can enhance things, which I think is a really good way to engage people, because we have truly, honestly, before I went into medicine, I had no idea what it was, right? There's all of these misconceptions and ideas of it just sounds very unpleasant. So it's really nice to make it approachable. So we had a bunch of talks with them. We had a big Q&A session, and also had some hands-on things. So we had a Cologuard kit with us so we could show patients what it actually looked like, because, again, even though it's non-invasive, the idea of handling stool doesn't sound pleasant to a lot of people, right? But knowing that, it's not messy like we think it'd be, it's very easy to do, right? Who would be good for? I thought there was a lot of great engagement with patients as well. So that was really wonderful. I think those events in the community are really what gets those people that maybe wouldn't have otherwise thought about it and placed importance in their lives with it, right? And I did have someone approach me to, have their family member establish care, right? And I've seen them and talked to them. I've had someone else that wanted us to talk to their other family member that was there to try and convince them to do something, right? So we were convinced them to do colorectal cancer screening, right? Whatever it was, right? We were able to go and directly talk to these people. And really the environment is such a huge, big part of things, because when you come into the doctor's office, you're not in your home environment, right? It feels like a foreign environment. It feels, we're all like that. I'm a doctor, obviously, and when I go to the dentist's office, I just automatically feel like I want them to tell me I did a good job, right? So we just kind of all revert to being like kids, right? That want to be told that we did a good job, or afraid that they're going to chide us, right? And even if you can be the nicest, most approachable person, people just have that feeling, right? That's why things like white coat high blood pressure are a thing, right? They just get anxious coming in, right? So when you're able to go to basically, this is their home base, right? You were a guest in their home base, right? And you're approaching things not saying that, I'm even, I am this like whatever fancy person, right? I'm just, when I come there, right, I'm Divya, right? I'm there, I'm here to talk to you, right? I'm here to answer your questions, right? I totally get where you're coming from, because I don't want to do these things either, right? But these are the reasons why. And I think it makes a big difference. So I was really happy that was a big part of our approach as well. And then I know there was another event this past week with the Hair Wellness Warriors. I know that the church that we worked with as well is having a specific men's health day as well, we're hoping to have some connections with colorectal cancer as well, because the one downside of our event was it was a lot of women, right? Because again, I think women are very still more invested in preventative health and getting involved with healthcare than men. So it's trying to figure out how can we engage people in a way that they'd be interested, right? So I really find it really rewarding, and I think it's great that this is a big part of our project.
Absolutely. Thank you so much for sharing that. Because I think, it's great to always encourage people to, go to the doctor, see their medical team and all of that. But I think sometimes the first step is, bringing people like you to them, meeting the people where they're at. And I think that, helps establish a little bit of trust. And I know you mentioned our event on Monday. So one of our hair wellness warriors in Chicago, Miss Regina, had her event at a beauty supply shop in the South Side. And I know, Dr. Balilos, you were, present and provided some great information to participants there. So if you wanted to share your experience with that.
Yeah, no, absolutely. It was so much fun. I think, we've kind of already alluded to this, but just really, it was a great example of really meeting people where they're at. And what really like stood out to me about it, and I was talking to Dr. Lee about it again, the gastroenterologist who we've been talking about, who was there. And I think like what my biggest takeaway from it was that, we have patients that come through our office all the time who like then decide not to get a colonoscopy. And that's one thing. And that's kind of what our colorectal screening tool is for, to kind of talk to them about their options. But there's a large proportion of patients that we're really missing who aren't even coming in the first place. And I think that's why it's this part of this aspect of this project where we're going to these community partners, and why all of you community partners that are joining us today are so important to this mission, because there's a lot of people who just aren't even coming, and we're missing them. And it's not that they just don't know, And so one of the big discussions that we had on Monday that I think really made a difference for a lot of people was talking about the prep for a colonoscopy, because a lot of changes have been made in recent years, and there's a lot of misconceptions that exist currently about colonoscopy prep, and just how miserable you have to be, and you have to drink, like 4 gallons of this stuff. And that is still a good, like, reasonable prep if that's the option you choose. But there are also options that you can now do that are like the small, and, so many people in the room on Monday were just floored, and it was so great because we were able to bring examples of it. And I had multiple people say, I'm going to call and schedule mine tomorrow. Like that was the big thing that was stopping me. So that's one thing. And then I think also going over all the other options as well. I think someone, maybe Jennifer, had put a question a little while ago in the Q&A. Oh yeah, and Faye had the same question, asking about the other non-invasive options. So we were also able to bring in some examples of those and kind of go over them and which patients would be appropriate for those options. Just to answer your question, there is Cologuard is the main one that you'll see. You see like TV commercials for it. It's something it's a DNA test of the stool, where you submit your full stool sample and you mail it in. And then if it's negative, you have 3 years until you do your next one. That's like the most studied option, and it's generally the one we prescribe the most in the clinic. There's also FIT testing, which tests for blood in the stool. And that's a once-a-year test, but it's like more of a smear of stool as opposed to like submitting your whole stool sample. There's also like a CT colonography that you can do, but we don't prescribe that one as often anymore. There's some other downsides to that. The big advantages of the 2 stool sample submitting ones are that you don't have to have anesthesia, you don't have to go in, you don't have to take time off work. It's a lot more convenient for people. Some downsides are that you aren't getting a look at the colon, and they have good data to show that they're good options. But if you do have a positive test, you have to get a colonoscopy anyways. And that's a conversation that as physicians we have with our patients when they're agreeing to do these tests, that, like making sure we're on the same page about if you do have a positive test, like we're going to have to proceed forward with the colonoscopy. I hope that answers your question. Those are like the 2 big ones, but Cologuard is definitely the most common that we prescribe.
Absolutely. Thank you so much for sharing that. I think, a big factor for our community partner events has been, reviewing the options. Because like you said, the colonoscopy can definitely, turn some people away from getting screened overall. But even, any option is better than no screening, I guess. So I'm glad that you guys have been able to share all this great information with the community in Chicago.
Thanks. Yeah. We always say the best test is the test that gets done. So,
Yes,
you know, you're not going to
absolutely.
do a colonoscopy. It's better to do the other one than nothing, for sure.
Absolutely. And
And
then
I
I
just,
did just,
sorry,
oh, sorry,
I
Dr.
wanted
Van
to
Kat,
add
go
one
ahead.
more thing. So just two quick things. So number one, right, the CT colonography is actually it's a decent test because we actually are able to get a look in the colon, but there's two reasons that honestly I don't recommend it very often. Number one is you still need to do prep, and I feel like a lot of times that's what people have a hesitation with the colonoscopy. So you still do need to do prep. And then two, there is radiation exposure, right? But if someone is willing to do the prep and they just can't take time off to do a colonoscopy, right? You are still getting a decent visualization of the colon, and it does give you a little bit longer than the Cologuard as well. I believe it's like 5 years. So it's something that's decent. And then the other thing that's kind of incoming, so not yet like on the market, but something that's being worked on, I think is maybe in phase 3 trials right now, is they're working on a blood test that's supposed to be part of a detection for colon cancer as well. It's, from what I've seen, it's not as good as the Cologuard. It's maybe, so if the sensitivity of Cologuard is I think 92%, this one I think is 86. So you're still going to miss some, and it is one that then we still would do yearly, right? From what I remember, but it's a great tool because some people, right, again, even if you say, oh, the Cologuard is easy to do, right, you still don't want to collect a stool sample. You still don't want to deal with doing all of the steps for a colonoscopy, right? But people get blood work done like the drop of a hat. Even sometimes they don't need blood work done and they want blood work done, right? So it's another really useful tool that I think it's going to help. It's certainly not going to replace any of the methods we have right now, but it's important to keep on the horizon too, because if that hopefully does go through and get approved and all of that stuff, we may be even reaching out to a bigger proportion of people where a lot of times when I'm doing lab work for someone and I just say, hey, do you mind if I also check an A1C to screen for diabetes? I know you want to do your cholesterol checked. Most people don't care. Most people will say, yeah, sure, right? And they may not feel the same way about these things that they have to do extra stuff for. But if you have this additional test and you say, hey, do you mind if I add on this colon cancer screening test? Maybe it's not the best test we can do, but it's certainly better than nothing. And it gives us a good amount of information. I really don't think you're going to get a lot of people that say no, unless there's a big issue with insurance coverage and cost. So that's another thing. I think there's a lot of headway that's being made in this aspect, right? Both with regard to screening and treatment. That'll be really important in the years going forward.
Oh, absolutely. And I think, both of you briefly mentioned our event with our church partner in the city, and, we're in the early conversations of a men's event with our church partners, which I hope everything works out for that, and you I get the pleasure of seeing you guys in person there. But Dr. Statler, I know obviously trust and partnerships are a big role in your scope of field. So is there anything that you would like to add to this as well?
As coming from the nursing paradigm, we are taught to take a holistic approach to care. That means we consider the patient, not only the physical aspect of the patient, but their emotional well-being and also their spiritual well-being. And so I think that partnering with these organizations like churches, partnering out in the community, and also using advocacy groups as a trifold effect, and also considering intervention development when it comes to research. I think that is critical where we are targeting populations that are hardest hit, and especially like my focus is on the African American men population because they have the highest incidence and highest mortality rate. But I think that I want to make sure just reiterate that question again. I want to make sure I'm answering it correctly. Leslie.
So I think just to go back to the work that you are doing in the city, of just the importance of building the trust and partnership, especially
yes,
since we're we mentioned earlier
yes,
that we saw a lot of women present at our events, but we want to target the other side.
Absolutely. So trust is critical. And we have to understand that every time we interact, whether it's the provider, patient role, it's the researcher or the participant relationship, that every encounter is a chance for us to either build the relationship or tear the relationship down. And we already understand that there's a deep history, that historical underpinning within the African American community where there's justifiable mistrust. And so, and that comes up, it resurfaces, it resurfaces. But, but when you have a good encounter, when you are boots on the ground is what we're hearing. The providers are out there at the churches. They're engaging with the community. They're educating. That's reducing the fear. That is building the relationship. And in that setting, you can actually improve. That's another strategy for hopefully improving colorectal cancer screening. Being
Absolutely.
hyper visible in the community is a key.
Oh, absolutely. I actually, this past weekend, I had the pleasure of attending our Hair Wellness Warrior event in Houston, and our partners at Exact Sciences were there supporting our work. So it was great to, be able to stop and, just chat. A lot of the attendees present were under the age of 45, but I think a big takeaway from that is somebody, within that age range, or there's, somebody that you love that you can still, bring this conversation up to. And that the information is, for everyone, whether you fit in that age group or not, or whether you, look like the typical person that should be screened. It's a conversation that should be had by everyone. And I think something that's really important is normalizing these conversations. Oftentimes, I think, our loved ones are the ones that encourage us to see the doctor or get, screening done or whatever that might be. But what are some effective strategies, for healthcare providers to be able to initiate the conversation surrounding screening? I know you touched a little bit on that with the tool that you have developed, but I think, anything to add to just being able to normalize that.
Yeah, I think one important thing to bring up, right, is obviously colon cancer is one of the most prevalent cancers, and also is a leading cause of cancer-related mortality. But also, right, is the fact that it's actually very treatable, especially if caught early. So I've had some patients tell me, like, I don't want these things done because if I'm going to die, I'm just going to die, right? I don't want to know about it and make that, traumatic for me and all of that, right? But they truly don't have to anymore, right? Especially if we're being really on top of things, we can catch things and then it's gone, right? It's not a big pivot of your life. It's not the main thing that's there. Some people may not be as fortunate, right? But treatment has come a long way. So that's a huge thing, right? And then the other thing, honestly, that I think is really helpful, even in patients, because you had mentioned too, maybe a lot of the people that came to the event in Houston were younger than 45, right? Unfortunately, the incidence of colon cancer in younger people has been increasing, right? And the important thing, too, that we're able to do to approach people is really tell them what are symptoms you should be worried about, right? What are things that would make us think that, yeah, it's a screening test, right? It's not something that you necessarily need to do today or you're toast, right? But if you're having something like blood in the stool, right? If you're having issues passing stool, right? If things are changing for you, that's an even bigger reason to say, let's do this so we can, if we figure something may be wrong, but if it's there, we can deal with it. I actually did have a patient that was younger, very recently in their 30s, right? That was literally just having blood in the stool. And both them and I were a little bit like, well, this is probably nothing. It's probably just hemorrhoidal, but the bleeding had increased. So we thought, okay, let's just do this, right? Let's just make sure. And they had a precancerous lesion, right? And now, even though they're not even the age range of screening, we now have to screen them again in a couple of years, right? So it's huge. It's something that seems so like nebulous and large and not really associated with us. And when you really say how it can affect someone's life and how it cannot affect someone's life by staying on top of these things, that's really, I think, how you reach out to people. And then again, like Leslie said as well, right? The family members are a huge reason people do things. So, I will admit, sometimes I am not shy about playing the guilt card and saying, yeah, I know that you don't care about this, but what about your granddaughter, right? Don't you want to be around for that? And you care so much about them. You talk to them all the time, right? And, it's not like forcing someone to do it, but then it reframes it and thinks about, yeah, of course, yeah, I want to be around for them, right? And this is something I can be around for. So it's really taking it to the personal level rather than just the huge population level.
Yeah, I think going off of that, like one of generally this may sound intuitive, but it's not often to some doctors, is like trying to, like, when you're starting the conversation, trying to figure out, like trying to understand yourself where that patient is coming from on all of it. So I usually start the conversation by saying, like, just like really, I keep it broad and I say, like, what do you know about colon cancer screening? Like, have you heard about it before? Have you ever thought about it before? Especially if it's a first time patient. And also trying, really asking, like, what are your concerns about it? Like, do you have any concerns about it? Are there any questions I can address? Because if you understand their specific concerns, you can then tailor that conversation to kind of reframe those concerns for them. Because most of their concerns will be something that you can address. And I think it's important to not lie to your patients and, be straightforward. You want to tell them this is what you can expect with each of these options so that they can then make an educated decision. But I do think that there are ways that you can address their concerns in an individualized manner. And I think that's really important.
Absolutely. Thank you. Anything that you would like to add, Dr. Statler?
Think that I want to just piggyback off of what has already been said that especially sharing the concerns, but I'm a very high proponent of patient advocacy, especially for them advocating for this themselves, as well as normalizing the conversation amongst family members. So I think it's important for the African American community to know if they are considered high risk for colorectal cancer, to have these discussions amongst our mom, our dad, our uncle. Do we have colorectal cancer that runs in a family? Do we have problems with bowel disease? Because then that can also change the narrative that you might have when you go into the doctor's office. You want to know what your colorectal cancer status is. I think that's a very, very important part to it as well.
Absolutely. Yes, and thank you for bringing up, advocating for yourself. I think, for me at least, even when I go into the doctor, if I have any questions, I make sure to write that down beforehand. Otherwise, I'm gonna completely forget, or sometimes I'm even scared to ask them myself. But I think, just thinking of advocating for yourself or your family members and normalizing the conversation, what are some questions that you think should be are good for people to have prepared when they go to see their medical providers?
So I want to answer that, but I also want to kind of pivot it to one of the questions that we got in the Q&A. So yes. To start off with, I guess, what questions we would ask, right? Knowing the options, right? Knowing what they entail, right? What they consist of as a responsibility from your part, right? Knowing that some of these things, if they're positive or negative, right? What does the next step go? But also super important is to know the limitations, right? So I think there was a question in the chat that had mentioned that someone's family member was diagnosed with colon cancer, but Cologuard did not catch it, right? And that's a very real thing that is possible, right? The sensitivity, right? The sensitivity, I believe, is 92%. The specificity, I believe, is 88%, which is pretty good, right? But it's not 100%, right? And that's something that's really important, right? Is if there is a family history at all. So if someone in the family has had colon cancer, right? If there's, other risk factors, like maybe there's other cancers in the family, there's inflammatory bowel disease, right? All of those things are reasons that we really then have one option, right? And the option is a colonoscopy. And that's mainly because we don't want to take that risk, right? And that's also another reason why, again, not a perfect system by any means, right? But that's also another reason why the screening times vary so much, because if Cologuard says, oh, we're fine, right? It's something really important to tell patients that some precancerous lesions are not going to be picked up with the Cologuard, right? So the first one may say, oh, it's not going to be fine, right? But the important reason that if they're not willing to do a colonoscopy, it's good to do it in another 3 years, right? Is because by that point, if there is something there, it may turn positive, right? Is that a guarantee? Unfortunately, no, right? But this is mainly our way of screening people that are, they're not willing to get a colonoscopy for whatever reason. And, a lot of people may have very valid reasons for that. So I think it is something super important that whenever we talk about these things, we should never, even colonoscopy, we should never basically make it as something that's, this is going to catch everything and it's going to solve everything, because all of these things, unfortunately, have downsides to them. And insurance is another, unfortunately, big annoying thing we have to deal with in the American healthcare system. So we've gotten to the point, right, that at least the majority of healthcare systems will cover preventative care, right? And that includes colonoscopies, that includes, Cologuard screenings, right? It is on a big impetus is on us to like bill it properly, right? But the majority of them do. There may be some out there that do not. I have not had the experience of those yet, thankfully. And then the other thing, I think, pivoting to another question that we had as well, super important, right? As this person brought up, that we have to be able to, yeah, it's great if we get them the Cologuard, but then if it's positive, great, they know it's positive. What can they do with it? Which is another big reason that, you need to have someone order the Cologuard, right? And so the health system that you get it in is super important too. So, for us, for example, if a patient is coming to me, right, and we take their insurance, and we're able to order Cologuard for them, right? The GI department is not different insurance-wise from us, right? So there may be individual providers that are different, but there is someone within the Rush system that also takes the same insurance plans that we do, right? So the same thing, right? Obviously, again, no system is perfect. The Rush system, unfortunately, does not take every insurance plan either, right? So it's figuring out, okay, let me figure out a health system that my insurance is okay with, right? And let me figure out a health system that I think is a well-connected health system. So it's another reason, right, when we find our primary doctors, right, it's nice to be able to go to a system where, even if it's not a university health system like Rush, right, where they have a connection, they say that, well, when I have patients that need surgery, they go to this other hospital, right? That's where I refer them, right? And the people that are taking care of you, the primary care doctors are taking care of you, they should know, right, that they're sending you to places that have the same insurance. If they don't, that's a failing on our part, right? And that's something that we do have to adjust. So totally not denying that there are big, speed bumps in this,
Yes.
right? And that's why it's super important for our perspective, not only to work on them, but also not to misrepresent to patients what these things are, right? To tell them basically, I will hopefully, right, I personally, and hopefully my colleagues too, will work with you to try and make this so it's not a cost issue you have to worry about, right? But there are limitations in the system, unfortunately.
Absolutely. I mean, I think, that's, as you're mentioning, a big speed bump is just, if it's not easily accessible, it can be discouraging for some. I think I'm located in Texas, so I've, helped our hair wellness warriors here in Houston be able to put together resources where, they have free or at least very low cost options within their city. So I think that's something that, health systems and clinics should definitely, help at least put together, is options, whether it's going to be, with them or with their health system, or being able to, be able to direct people of where they could be able to access these screening tools. I know we're coming up on time here, but I just want to make sure we get to our Q&A. And I think we might have answered this a little bit, but how do we tailor those conversations with vulnerable populations? And I know, Dr. Blues, I really like the point that you brought up of, maybe not doing it for yourself, but doing it for your loved ones, I think is, good. Or I think the best way to set this up might be, sitting down with whether that be your patient or, your family member, and just seeing what it might be that they care about, or, what might make them feel a little bit more comfortable. Any other thoughts that you would like to include to that?
The only thing I would
Yeah,
add
go ahead.
to is, oh, sorry. The
No,
only thing
no,
I
go
would
ahead.
add to is
Go ahead.
just asking patients, maybe asking people why they don't want to do something instead of assuming, right? And asking them to, the way I like to start out a conversation a lot of times is, what do you know about this, right? Because we have all these assumptions, right? And usually they're wrong, because usually we're approaching it from our own life.
Absolutely. And I think something else that really helps is, somebody else had dropped in a question, but when thinking about myths, anything that we, are able to dispel, or, I'm sure we've had a few questions of misconceptions during our community partner events, but I think, breaking down myths is probably a great way to also start a conversation like this.
And I think I wanted to add one more thing to this. I think
Yes.
that's very, very important. There are African American and minorities that are following through with colorectal cancer screening. and they're doing it in a timely fashion. So one way we can tailor our message is by going to those people that are actively getting it done and asking them, what barriers were you seeing while you were trying to follow through with your colorectal cancer screening? And what are some of the things that you think would make it, what ways can we go about helping people that are not getting screened? Because I think, some of the answers they will have themselves. Our community will have the answers to some of the barriers that exist.
Oh, absolutely. And I think our team at Rush with Dr. Balilos and Venkat did a great job of that, of, knowing, how can we tailor our events, or how can we tailor our work? And, we were able to have a sit down conversation with our Faith Health Alliance church partners in the city to be able to really, learn, because, we can only think of, so much, but we want to make, the work that we do, we want to make sure is going to be useful and tailored to the people that we're trying to reach. So I think that's probably one of the most important things.
One of the other, I guess this is the last thing I'll say on this, I'm sorry, but one of the other techniques that sometimes I'll use too, because we've talked a little bit about trying to normalize conversations amongst family members, but also just trying to normalize the conversation in general. I think like colorectal cancer is kind of like, to a lot of people, a lot of patients, race aside, an uncomfortable topic, and specifically is maybe more uncomfortable to certain races on average, but it's an uncomfortable topic, like at baseline. And so I think like a lot of the time too, if you notice that a patient is or even like if you're a community partner and you're trying to normalize the conversation, you can start by saying like, this is an uncomfortable topic, and you can really just address it like that and say, we're trying to normalize this because some people may, like, you can make generalized statements. Like some people might think that it's weird because of this, like this makes some people uncomfortable. Does that make you uncomfortable? Because then it's like, they're not alone, and I think that's really important, is that like, we're all in this together.
Absolutely.
I'm not looking forward to getting a colonoscopy either, but I know it's something I have to do. So I think that's a big part of it as well.
Absolutely. And I know we're coming up on time, but I think I wanted to close this out with a little bit of a question of, what our hopes are for the future of colorectal cancer, especially with screening. But where do you think we're headed? And, what do you hope to see, especially when thinking about access and the disparities that we're seeing in this space? Dr. Balilos, if you wanted to go first.
Oh, sure. I think that, with everything that's what we're seeing in the news with it becoming more common in younger populations, I think that we're headed towards just more screening in general, especially colonoscopies for higher risk patients. With that being said, though, that there's so many new options, and I think the technology is only improving, and it's going to be a while before we figure out the clinical and actual practical utility of all of this new stuff. And I do think that, colonoscopy is going to be the frontline management, at least for the foreseeable future. But I think that it's an exciting time because we have a lot of new things coming out that are going to make access ideal. Hopefully, at least my hope is that it's going to make access to colorectal cancer screening improved. And we'll just have to see. Well, we may be limited by the system as always, but we'll do our best.
Yes, absolutely. Dr. Venkat, where do you hope that we head in this space, especially with access and disparities?
Yeah, I think that maybe this is like a lofty ideal, right? But honestly, we should be treating all patients the same, right? All patients that have the same access, right? I mean, this is a completely different tangent, right? But your insurance shouldn't dictate whether you get good health care, right? Where you live shouldn't dictate whether you get health care, right? And your education shouldn't either, right? Which is, I think, a huge reason why, we're training more doctors nowadays to be more patient-centric, right? The lens has changed completely. Like the doctor is no longer the big person sitting on a chair, right? And that's, I think, huge, right? And now it's that, maybe not with colorectal cancer, but with pap smears, for example, all the time I tell patients how much I hate pap smears, right? But then we have to do it, right? And then the other thing that makes sense, right, is one of the comments in the Q&A had said people are afraid of the result, right? Honestly, I am very upfront with people, right? The result is scary, but not testing is not going to change the result. It's just going to make you not be able to do anything about it, right? So being able to do the test and get that information gives you that power back, and that's the thing. I think a large part of it is showing people that we're not at this phase anymore where I just tell you what to do and you do it, right? We're at a phase where we
Yes.
empower you to take charge of your health and, you know, live your life in a way you don't have to worry about it. And that's really the hope, is that we really need to work on healthcare education to make sure that everyone has the info they want to know. People don't have to feel silly for not knowing things.
Absolutely.
I'll be perfectly frank, until I saw the Cologuard test at the church event, I did not know what it looked like, right? It sounded weird to me too. And then I looked
Yeah.
at it and I thought, oh, this is not as gross as I thought it would be, right? So it's
Absolutely.
all of these things that you can, you know, we all, you know, you can think you can be the most educated person ever, right? And there's going to be some stuff you do not know, and that's okay, because at some point we all didn't know that, right? And just, you know, showing that your faults are there too, right? Showing that,
Mhm.
you know, we want to do this because we want to help people, right? So that's the main thing.
Absolutely.
That's the thing to bring back to it, is it's scary, it stinks, it shouldn't be there, right? But if it is there, let's help you with it.
Perfect. And Dr. Zettler, we're running out of time, but real quick, where do you hope to see, you know, that we're heading in this space?
I hope to see that we continue to work together and partner with the communities in developing tangible interventions that are targeted towards specific populations that are suffering the most from colorectal cancer. And so that we are actually moving the pendulum when it comes to colorectal cancer screening. I want to see a tangible, objectable evidence that more people are getting screened. And you see that the National Colorectal Cancer Roundtable has a goal of 80%, that we're heading in that direction.
Absolutely. Well, I wanted to thank you all so much for joining us today and sharing your expertise. It's been a great conversation, and I'm sure everybody learned a great amount of deal. But I want to see if Brandon, I'm not sure if you wanted to sign us off or share any other information before we close out. I'm not sure. Well, I can close it up.
He might be away from the computer.
Okay, no worries. But thank you again, everyone, for joining us, and I hope everybody has a great weekend.